to inform future events, trainings and engagement. So we really would value your feedback on the topics discussed. And we've got a feedback QR code, which will be shared at the end of the meeting. So it just remains for me to say, for general housekeeping, thank you for attending today. Next slide, please. So we've got an absolute fantastic agenda today because we've got some really, really brilliant speakers within the field of Lynch syndrome. So we're going to be, our first speaker will be Fiona Lalou, then we're over to Kevin Monaghan, Professor Emma Crosby. We will have a slight intermission for 10 minutes at 10:50, and during that time we will play our spills video, which is a simulated patient interview for Lynch syndrome. Then we'll be going over to Professor Jim Hill and Mandy, who is our regional Lynch syndrome clinical nurse specialist nurse educator, and will be really giving us that great nursing perspective. And then we're really excited that we're actually going to have a discussion on the topic of Lynch syndrome as a specialist MDT, and then we'll draw to a close by 12:30. So thank you very much. I can see that we've got quite a few of you joining. So that's just the welcomes over and done with. We are going to be recording it for those who have only just joined, and we can start recording now. Next slide, please. So one of the most important things that we as a team here in the Northwest GMSA recognised is that we wanted to be able to reach out to all you clinicians across the region and Cancer Alliances and anybody else that has got an interest in changing things for patients. So we came up with the concept of the REEF series. So REEF is simply Regional Engagement and Education Forum, and it really is patient centric. You know, we really do need to listen to the patient story to keep us grounded and make sure that all that we're doing is patient centric. We want to hear from the professionals. That's the professionals who will be speaking, but also yourselves there in the audience, whichever department you're in or field of work, you know, please engage in the chat and indeed ask questions. And again, for practitioners, those people at the grassroots level who are actually looking towards embedding Lynch syndrome within their clinical pathways. So the next slide will just show you that how we want to engage with the Northwest and indeed wider and further afield is we want to engage because it's through engagement that we're then able to offer educational opportunities, and it's the education that then will enable you all to truly understand how important and how to embed Lynch syndrome testing within your clinical pathways and just how important that is. So next slide, please. Next slide, please.
I think this is me, is it not, Marie?
It is. I'm just getting. Have you taken control?
No.
No, Rainis, can we go forward with the slide, please?
It should have gone forward.
Yeah, so I can see me.
Oh, perfect. Lovely. Thank you. Fiona, I'll let you introduce yourself because I can't see the slide now all of a sudden.
Okay. So I'm Dr. Fiona Lalou. I'm a consultant in clinical genetics based in Manchester, and I'm just going to give you an overview of Lynch syndrome. Next slide, please. So if you see these sort of patients in clinic who come to see you who've got an early onset malignancy and they've got a really significant family history, it's pretty easy to diagnose Lynch syndrome, which is a predisposition to bowel and endometrial cancer. And this fulfills Amsterdam criteria, which is that there are at least 3 cases of Lynch-associated cancers in the family across 2 generations, and one of which was diagnosed under 40. So this clearly is a family in which there is an inherited predisposition to malignancy. And Lynch syndrome is caused by mutations in mismatch repair genes. Next Slide, please. So within our cells, there are always mechanisms to repair DNA damage. So at the point of division and replication, there are always mistakes made, and so there's a whole mechanism within the cells to rectify these mistakes, and these are the mismatch repair genes. And it's the mismatch repair genes in which, if you have pathogenic variants, you will go on to develop Lynch syndrome. Next slide, please. And there are mutations in 4 of these genes, so MSH2, MSH6, MLH1 and PMS2, all sitting on different chromosomes. Next slide, please. Pathogenic variants in these mutations will give you different risks of cancer. This is taken from the Prospective Lynch Syndrome database, which is an international collaboration collecting data on patients who have Lynch syndrome and prospectively monitoring them and seeing the risk of malignancy. The PMS2 data is likely to be an underestimate because there are very few cases of PMS2 within that cohort. But the other genes, there are large numbers of patients. And what they're showing is that if you have a pathogenic variant in MLH1, you have a lifetime risk of colorectal cancer varying between sort of around 50%, slightly higher for men than women. Whereas with MSH2, again, you have a high risk of colorectal cancer. With all of these genes, there's also an increased risk of endometrial cancer. The risk of ovarian cancer is increased with MLH1, MSH2 and MSH6. The data on PMS2 is poor. There's also an increased risk of urological malignancies, in particular transitional cell carcinomas of the ureter associated with these genes. Next slide, please. There is an online web page for the PLSD data, and this is really interactive and really helpful. So you can enter the organ of which you're interested in the risk. So in this one, we want to know the risk of colon cancer in someone who's got a pathogenic MLH1 mutation. You put in the age of the patient and you put in the sex of the patient, and then you get this graph which will show you the risks and also data table showing you risk at given ages. And this is really helpful because it means you can give your patient a good risk estimation of at the age they are of what their likelihood of developing a malignancy in the next 10 years or over the remaining lifetime is. Next slide, please. So Lynch syndrome is autosomal dominant, and just to remind you, that means that you have 2 copies of each of these genes, of which one has a pathogenic variant. So there is therefore a 50% or 1 in 2 chance of passing that on to your children, and therefore a 50% or 1 in 2 chance of first degree relatives, i.e. parents, siblings or children having that mutation as well. The testing within the families will all be undertaken by the regional genetics service. That is not undertaken by Mainstreaming. And so any patient who has Lynch syndrome diagnosed within the Mainstream arena needs to be referred into the genomics service for the further discussions about family testing to take place. Next slide, please. So the first pedigree I saw you, it was pretty barn door that family had Lynch syndrome. This pedigree, however, is more common in terms of knowing there's someone who's got a colorectal cancer at a youngest age, but not that young. There's a query about whether there's a gynae cancer in there, and we don't really know. And traditionally, these are the sort of families who would be missed because that family history isn't diagnostic of a clinical diagnosis of Lynch syndrome. But this is the sort of family that we know we are identifying mutations in. Next slide, please. And because of this reason, because family history is a poor discriminator, there was a nice committee assessing the molecular testing strategies for Lynch syndrome in people with colorectal cancer. That was published in 2017. A similar one was set up and published in 2020, looking at those individuals with endometrial cancer. And both of those guidelines issued recommendations saying that all people who have a diagnosis of colorectal cancer or who have a diagnosis of endometrial cancer should undergo tumour testing in order to try and pick up Lynch syndrome. Next slide, please. The other driver around diagnosing Lynch syndrome was this paper that came out in New England Journal of Medicine demonstrating that in the colorectal carcinoma arena, those patients who had deficient mismatch repair, i.e. loss of mismatch repair in their tumour, responded much better to the checkpoint inhibitors, with having a remarkable degree of progression-free survival compared to those patients who had proficient. And so there were two drivers to initiate Lynch testing. The first being able to diagnose Lynch syndrome more accurately, but the second to allow for prescription of checkpoint inhibitors for those patients who had a high risk cancers. Next slide, please. There was an expert consensus recommendation suggesting that whilst we knew how we could diagnose Lynch syndrome, it wasn't being done terribly well. And that consensus documentation suggested that there should be development of a Lynch syndrome registry, that there should be a quality assured surveillance programme for patients who had Lynch syndrome, and that there should be a dedicated clinical champion for hereditary colorectal cancers within every colorectal MDT. Next slide, please. And this is old data from 2019 showing the level of tumour testing for mismatch repair using immunohistochemistry or MSI in the cancer alliances. And what you can see from this data is that it was patchy, and even the best cancer alliances were not hitting much more than 70% of tumours being tested. Next slide, please. So therefore, NHSE, with a group of experts, implemented Lynch syndrome testing and surveillance pathways, which set out how you would instigate the plan for the NICE guidelines in terms of ensuring that all patients with colorectal cancer and endometrial cancer were offered appropriate tumour testing and then downstream pathways. Next slide, please. So these pathways I'm going to show are for all the colorectal cancer pathways, but they are very similar for the endometrial cancer pathways. So essentially, there was the option of using IHC. What they were suggesting is that the pathway for IHC could be done within the mainstreaming pathway. So biopsies were sent to pathology, immunohistochemistry undertaken, and for those patients who had an MLH1 or PMS2 variant or an MLH1 isolated variant on IHC, they should have BRAF and hypermethylation testing. And for those patients who had a deficient tumour of MSH2, MSH6 or PMS2, they should go straight to germline testing. And that testing could be done either within the genetics service or could be done within the mainstream cancer team. Next slide, please. And this is the same pathway, but using MSI rather than IHC. MSI is not used within the endometrial cancer pathway because it's non-discriminatory. Next slide, please. And then once the results have come back showing that there is an abnormality of the tumour, suggesting that the patient does need germline testing, then the options are to do that germline testing within the cancer team or to refer the patient into genetic testing. And then you then need to, looking at the results, if you find a pathogenic variant and that patient has Lynch syndrome, they need to be referred into the clinical genetics service. Depending upon the age of the person you're testing and the family history, you can either reassure at that point or then go on to doing tumour testing to identify somatic variants which would account for the abnormal IHC. Next slide, please. So this is the pathway. This is immunohistochemistry or microsatellite instability. Remembering that actually if you're dealing with endometrial cancer, it's just IHC. If you have loss of MLH1 or MLH1 and PMS2, you move on to the BRAF and methylation studies. And depending on the results of that, you can offer germline testing. The reason you do BRAF and methylation studies is because a high proportion of methylation, tumours that show loss of MLH1 are due to somatic variants caused by methylation of BRAF. Go on to the next slide, please. So if you have a BRAF mutation or have methylation, you can then reassure the patient that although the initial tumour testing was suspicious for Lynch, that the diagnosis is unlikely to be Lynch. If you've got normal methylation or a BRAF wild type, you then need to go on to mismatch repair testing of the germline. And that, as I said, can be done either by referring the patient into the genetics service or by undertaking tests locally following the appropriate consenting process. Next slide, please. So the crucial role of people at the MDT is to make sure that that initial step is done, is to ensure that with every tumour, whether it's colorectal or endometrial, the immunohistochemistry or the MSI test has been done. And to make sure that once that test has been done, the results have been received and the results have then been acted upon. If you have abnormal IHC with loss of MLH1, then there is, from the pathology service, there should be a reflex system for sending those samples across to the genomics laboratory hub to undertake the BRAF or methylation studies. It's then important that once those results are back, either the patient undergoes germline testing or you refer appropriately to the genetics service. And that's the main role of the MDT. But the most important thing for the Lynch champion is to ensure that that initial testing is done, because that is the diagnostic testing. All the downstream pathways can be picked up by referring patients into the genetics service. But unless we do that initial test, we are not taking the opportunity to diagnose Lynch syndrome in these individuals. Next slide, please. And so, as I say, once you've diagnosed a patient with a likely pathogenic or a pathogenic variant in one of the mismatch repair genes, all patients need to be referred to clinical genetics. And then in genetics, we will discuss management of that individual and then of the wider family. Next slide, please. So the way that you would offer screening to individuals is that you would offer colonoscopies on a 2-yearly basis. That has gone into the National Bowel Screening Programme from today. So the first patients have from the prospective arm will have been referred and enrolled into the National Bowel Screening Programme today. So for patients who have an MLH1 and MSH2 pathogenic variant, they're offered colonoscopies on a 2-yearly basis from the age of 25. For MSH6 and PMS2, it's from the age of 35. The screening for endometrial malignancy is really not a huge amount of evidence around it, and screening is patchy, but in Manchester we would offer hysteroscopy and pipelle biopsy annually from the age of 35, or discuss risk reducing BSO and hysterectomy once the patient has reached or has completed her family or has chosen that she wishes to undergo surgery. That discussion is taken within the genetics service. The only way of ensuring the patient gets into the National Bowel Screening for their regular colonoscopies is via the genetics services. We will then refer the patients via the NDRS portal into that system. Next slide, please. And this demonstrates the utility of undergoing screening, in that those patients who are not screened have a much higher risk of colorectal cancer than those who do. Next slide, please. And again, this is data suggesting that those patients who have Lynch syndrome, even if they develop a malignancy, have a much earlier stage and therefore have a much better prognosis. Next slide, please. And so the aim of this is to ensure that we're not looking at the sort of pedigrees now that we see in the first slide, and that this last generation, we are able to diagnose Lynch syndrome in their relatives. We're then able to offer predictive testing to people who do not have a cancer, and to make sure that they can then go into the appropriate surveillance programs in order to prevent malignancy, or pick it up at an early enough stage so that they do not die from the disease. Thank you. Next slide, please. Any questions?
If anybody has a question, they can pop it into the chat if they haven't got one that they want to ask now. But please put your hand up if you've got any questions for Fiona. Fiona, that was absolutely great. Thank you so much. Just demonstrating how important the pathway is. And it just strikes me that, the cascade testing is so important, isn't it, for identifying these not known yet cases.
Yes, yes, it is.
Yeah, so really is fundamental. Thank you so much for another brilliant presentation. And thank you so much for joining us.
Thank you.
And we can go to our next slide. So we are delighted. We're building on Fiona's presentation there, and that really important understanding of the pathway here that we're dealing with. But we're going to go now to Kevin Monaghan, who is going to give us the perspective of the National Lynch Syndrome Project. And again, we're indebted to Kevin for his support for the webinar, as Fiona, and he's given us a recording. So here's the recording.
Hello, my name is Kevin Monaghan. I'm a gastroenterologist at St Mark's Hospital in London and one of the leads for the National Lynch Syndrome Project. And it's my pleasure to speak to you today. I'm sorry I can't be there in person. I'm going to tell you today about some of the overlapping national work that's going on in this area. But before I get into that, I'm going to illustrate some of the issues that we need to think about with a real case. So this was a 65-year-old man who was diagnosed in May 2019 with a colorectal cancer of the splenic flexure invading the DJ junction and attached to the stomach and pancreatic tail. He had somatic next generation sequencing, which demonstrated that he had no mutations in the tumor in RAS or BRAF genes. And he was commenced on chemotherapy with Capox. Unfortunately, the tumor increased in size whilst on chemotherapy. And because of fistulization of the tumor into the jejunum, he required TPN and a venting gastrostomy. In November 2019, he had further disease progression with 2 probable liver metastases. And in December of 2019, it was decided that he had exhausted chemotherapy options and he was discharged home on best supportive care. This is his CT scan following chemotherapy. And as you can see, there's a large locally invasive mass in the splenic flexure, and it's fistulating through to the jejunum. So he had no clinical response to chemotherapy. He's sent home on palliative care, but he has an amazing daughter, and his daughter, who was studying her final year of biomedical sciences, asked to see a copy of the path report and saw that there was immunohistochemistry which demonstrated isolated loss of MSH6 protein, indicating this is a mismatch repair deficient tumor, which may potentially be as a consequence of Lynch syndrome, maybe not, but this had 2 important implications. And she arranged for her father to undergo genetic testing, and she arranged that he'd be referred for immunotherapy. He was then diagnosed with Lynch syndrome with a pathogenic variant, or what we used to call mutation, of the MSH6 gene. And after only a very short period of treatment with checkpoint inhibitor immunotherapy, for which he's eligible because of his tumor mismatch repair status, he had complete clinical response in between January and April of 2020. At this point, following that short period of immunotherapy, there's no evidence of tumor anymore. And in fact, the main difficulty that we have is trying to perform colonoscopy on him. It was referred to us at this point, and the colonoscopy is challenging because he has a fibrotic stricture in the colon, but no cancer anymore. So how common is this Well, in a colorectal cancer MDT, about 1 in 6 patients will have a mismatch repair deficient tumor. So it's something we've been encountering every week at our cancer MDT, and it's more in more endometrial cancer patients. Lynch syndrome is a common disease. It affects about 1 in 400 people in the UK, and similar figures in the US based on the best available epidemiological data. And therefore, there are about 200,000 people with this condition. However, we've only ever diagnosed about 11 or 12,000, and therefore we're missing 95% of patients with Lynch syndrome, and they can't avail of the many opportunities that we have to prevent cancer and treat cancer more effectively. As a consequence of this and other factors, NICE have recommended universal testing for all new diagnoses of colorectal and endometrial cancer. Lynch syndrome causes about 1 in 30 cases of both these cancers, actually, about 2,500 cancers overall annually in the UK, of which just under half are colorectal, and the remainder other predominantly epithelial cancers, especially gynecological cancers. The 10-year cumulative incidence of colorectal cancer is between 8% in high-quality colonoscopic programs to 11 or 12%. And the risk of cancer for colorectal and other cancers is related to which underlying gene is at fault. So for colorectal cancer, the high-risk genes are MLH1 and MSH2, and we start colonoscopy 10 years earlier for these individuals. As I said, NICE have recommended that everyone who's newly diagnosed with colorectal or endometrial cancer undergo testing. And this is the algorithm for colorectal cancer, which involves lots of steps. But essentially, when you have a new diagnosis of colorectal cancer, you can either have mismatch repair testing with a test called MSI, which is performed in some areas, but overall in England not as frequently as immunohistochemistry, which is predominantly performed as a test for mismatch repair status. And if these tests are abnormal, it doesn't mean that you have Lynch syndrome. It means you may need to undergo further testing, either further tests in the tumor or a genetic test. So there are lots of potential for the tests in the tumor, but essentially it's the genetic test that at that point that we can say someone has Lynch syndrome or not usually. Lynch syndrome is a genetic diagnosis, and the previous tests don't tell us that the patient has Lynch syndrome necessarily, just that they may have a mismatch repair deficient tumor. And they might have Lynch syndrome. How is this testing implemented? We know it can be implemented in DGHs or ivory towers, but often it's not. The Freedom of Information Request report from Bowel Cancer UK was reported in a story in the BBC in 2018. You may remember Stephen Sutton, who unfortunately passed away in 2014 at age 19. And he had previously gone to his GP with symptoms. His father, Andy, had Lynch syndrome. He said to his GP, I have Lynch syndrome and I have symptoms. And the GP did not know what to do because the GP wasn't properly equipped to manage this kind of individual. Unfortunately, when he was referred, he had advanced disease. And these days, he would have access to immunotherapy, which wasn't available then. And that might have changed his outcome. But, we won't know really. In retrospect, it's easy to say. But what this kind of partially represents is something called a diffusion of responsibility. Nobody knows exactly who's responsible for managing these patients, but they presume that maybe somebody else is dealing with it. And that kind of diffusion of responsibility is something that's been observed throughout secondary and tertiary care, in fact, in the diagnosis of these patients. So if we take another piece of data, if we look at, this is data from National Disease Registration Service in 2019, if you test efficiently and without any excess testing, you should be offering a genetic test to about 6 to 7% of colorectal or endometrial cancers. And in fact, this is data from every single cancer diagnosis in 2019 across England. And less than 1.5% of patients are actually receiving a genetic test. Therefore, most patients who should be having the test are not being tested. When NICE guidelines were published around about the same time, we had a multi-society meeting at the Royal College of Surgeons, and we developed a plan to develop a national registry a quality assured surveillance program for Lynch syndrome, which would include bowel cancer screening. And we recommend that there should be a clinical champion responsible for Lynch syndrome testing within every cancer team, which is now within the NICE quality standards QS20 for colorectal cancer. We developed these ideas into 3 national projects: the Genomic Medical Service National Transformation Project, sometimes called Finding the Missing 95%, which is focused around moving from a diagnosis of cancer to a diagnosis of Lynch syndrome, particularly for colorectal and endometrial, but not only for those cancers. Secondly, there's the Lynch Bowel Cancer Screening Program, which is launching in July, later this month. And thirdly, I'm not going to speak so much about this, the National Lynch Syndrome Registry, which is a hybrid academic project with NHS Digital and specifically NDRS. So first of all, the National Transformation Project is about diagnosing Lynch syndrome effectively and delivering diagnosis in patients who should be offered testing and should be, but are not being offered testing or weren't being offered testing previously. It's linked to the Genomic Medical Service goal, which is to embed genomics in routine clinical practice. And we've developed training to try and ensure this can be delivered, which you'll be hearing more about today, no doubt. The diagnostic pathways, there should be responsibility within individual cancer MDTs. Genetic services will never know about the patients that they are not referred. They rely entirely on referral, and therefore, at a bare minimum, we need to be able to identify patients who should be eligible for genetic testing and refer them effectively. In fact, what we would like optimally is that genetic testing is provided locally by cancer teams, by oncologists, surgeons, CNSs, gastroenterologists like me. And we've developed a method of trying to measure this and measure performance. This testing by local cancer teams can be supported regionally by expertise from clinical genetic services, from specialist gynecology and colorectal services, amongst others. And this is linked to the bowel cancer screening project through the National Lynch Transformation Program. We have ascertained all historical diagnoses of Lynch syndrome and fed them into the screening program project. We've developed online training modules, which are free, come with certification. There are training modules for colorectal cancer MDTs, for gynae oncology MDTs focused on endometrial cancer testing. We've developed training modules with the Royal College of Pathology, specifically with Nick West, for pathologists, including standardization of reporting manuals. We've developed training for primary care. For busy GPs, we've developed a short 7-minute training module, and this is designed to ensure that when someone like Stephen Sutton goes to his GP, it's easy for the GP to manage this patient. And therefore, the modules are designed to be short, discreet, and really focused and well within the scope of our clinical practice as cancer MDT clinicians. We're developing regional expert networks to help support this testing process, and also to help deal with some complexity in clinical management. For example, where there are complex clinical issues that require multidisciplinary input from gynecology or from colorectal surgery or from genetic services, for example. If you think about where we need to get to, well, with NDRS, we've developed data which is available to anyone with an NHS email from the website Cancer Stats 2. And this data tells us that not only was genetic testing falling down, but mismatch repair testing was well below expectations in 2019. So in 2019, only 43% of colorectal cancers had any form of testing, never mind genetic testing for Lynch syndrome. And for endometrial cancer, it was low, albeit this is before the endometrial cancer NICE guideline. When we look at the length of time it takes for someone to have testing following a diagnosis of cancer, so the index mismatch repair test takes across England typically 24 days, which is really quite long. In fact, some centres and many centres, this can be turned around within a week, and I think that's a reasonable target. What's called follow-up testing, which is methylation or BRAF testing, takes a little longer again than we would like. And germline or genetic testing takes almost a year, maybe quite a bit longer. And in fact, since the pandemic, many genetic services have a waiting time of over a year. And therefore, we're benefiting our patients if we're offering this testing to them locally in parallel with their cancer treatment. This is data from our Cancer Alliance. I'm sharing the names of the sites because this is data which is publicly available. But as you can see, within our Cancer Alliance in London, there's a huge level of variability in MMR testing, and some sites are doing this much more routinely than others, but none were perfect in 2019. I'm glad to say this is significantly better since then because of the intervention. We have audited individual services to identify where the bottlenecks lie. Is it with the first step? Is it with the intermediate step in testing? Or is it with referral for genetic testing? And we found that although in our own geography, and this is just as an example, audit data demonstrated that most patients were having immunohistochemistry, but beyond that, the pathway was falling down. And we tailored our interventions according to the needs of specific needs of individual MDTs. The audits that we're asking from individual cancer MDTs across England are designed to help offer support which is specific and relevant to those local cancer teams. So the audit data is really for the teams that are providing it so that they can be advised about how to ensure effective delivery. And through this program so far, based on this audit data, the mismatch repair testing rates have increased to almost 90%, 89% for endometrial cancer and well over 90% for colorectal cancer. But this is the first step in the pathway with immunohistochemistry or the MSI test. What happens next? Well, we need to move towards this mainstreaming model. This is diagnostic genetic testing by clinicians who are not geneticists or genetic counselors. So this is people from cancer MDTs typically. And amongst patients, this kind of testing has high levels of acceptability and satisfaction. The referral time is much shorter if patients are offered testing locally, and they are being tested by clinicians with whom they already have a trusted clinical relationship. Through this, we've established 66 new mainstreaming tests, or clinics, across England. And we want you to join us if you're not doing this already. We're here to support this. I'm just going to talk briefly about the Lynch bowel cancer screening program. As you diagnose patients with Lynch syndrome, you need to offer them optimal clinical care. And that includes 2-yearly colonoscopy. This has been extrapolated to provide 7 years of life for patients who undergo 2-yearly colonoscopy. With the bowel cancer screening program project, patients will have good experience and comfort, which is especially important in this population where they may need 25 colonoscopies over the lifetime if they start at 25. Bowel cancer screening colonoscopists undergo a driving test, and therefore what was called a driving test. That means that the key performance indicators are high and their ability to detect subtle lesions are at the highest level. The images you can see here are 3 surveillance detected colorectal cancers, and I think you will agree these are extremely subtle and difficult to detect, even for experienced colonoscopists. Through the screening program, the patients will be offered timely colon recall. Many patients currently have to wait often 4 years for a colonoscopy and struggle to access the repeat procedure. They go to a GP maybe who doesn't know so much about Lynch syndrome, and then they have to be referred to secondary care to someone who hasn't maybe seen them before. And this will ensure that they don't ever have to face those barriers again. And this also provides opportunities for structured interventions, and the planned go date is later on this month, as I said. We ascertained all historical diagnoses through the national project, and this data has been fed into the National Disease Registration Service. They've then cleaned up the data and they've shared it with the bowel cancer screening hubs who are sending the invitations. And many of you, if you're working in the screening services, will have been phoning patients over the last few weeks to welcome them to the program. Who's eligible? Anyone who has a genetic diagnosis of Lynch syndrome, who has any large bowel, who's known to a genetic service. So if they've moved from abroad and they've never been linked into a genetic service, they can be referred to that service who can then enter them into the screening program. They need to be registered with a GP in England. So if they're registered in Wales, for example, they won't be invited. And they need to be eligible according to their age. So if they're too young or too old for screening, then they won't be automatically invited. So there's a lot going on in this field, which is incredibly positive. There's the bowel cancer screening program, Lynch Project. There are new therapies, immunotherapy, which can be highly effective in many patients. They don't work in everyone, of course, but this is a real breakthrough in patients with mismatch repair deficient tumors. Gastroenterologists and surgeons and oncologists can offer genetic testing, and we're trying to improve the method by which we offer care overall. So thank you very much, everyone. I hope you have a good session and a good day. Thank you.
Thank you to Kevin for such an in-depth and really enlightening presentation there for colorectal cancer pathways for Lynch syndrome, and demonstrating all the progress that has been made to date, which is really truly exciting. And now we're going to go over to endometrial cancer in Lynch syndrome, and we're delighted that we've got Professor Emma Crosby presentation to give, and again she has very kindly given us a video, so we'll go over to that now.
Hello, I'm Emma Crosby. I'm a Professor of Gynecological Oncology at the University of Manchester and Manchester University NHS Foundation Trust, and I'm going to talk to you today about endometrial cancer in Lynch syndrome. Lynch syndrome is the most common inherited cancer predisposition syndrome that's thought to affect around 1 in 300 of the general population, yet only 5% are aware of their diagnosis. Lynch syndrome is caused by inherited pathogenic variants affecting one of the 4 mismatch repair genes, MLH1, MSH2, MSH6, and PMS2, that together are responsible for ensuring fidelity during DNA replication. Lynch syndrome is inherited in an autosomal dominant way, meaning that a parent passes on Lynch syndrome to approximately half of their children, whether they be girls or boys. Lynch syndrome increases the risk of colorectal, endometrial, and a range of other different cancers, and these cancers often occur at a young age, and furthermore, a person is at risk of more than one cancer diagnosis during their lifetime. Endometrial cancer is often the first cancer in women with Lynch syndrome, and as such offers an important diagnostic opportunity. And this is because identifying Lynch syndrome enables bowel cancer screening, aspirin chemo prevention, and cascade testing of at-risk family members, which are all interventions that have been shown to save lives in Lynch syndrome. When we started looking at this around 5 years ago, we noticed that despite similar risks of colorectal and endometrial cancer in Lynch syndrome, there were huge disparities of care. So for colorectal cancer, NICE had already issued guidance, recommended the universal screening of all colorectal cancers for Lynch syndrome. There was an established Lynch syndrome testing pathway. There were national and international clinical guidelines guiding clinical care teams as to the best approach. And indeed, there was evidence-based cancer surveillance for healthy carriers of Lynch syndrome to identify early cancers and precancerous lesions of the bowel. But none of this was true for endometrial cancer, and we wanted to do something about it. So we paired up with Lynch Syndrome UK, which is a patient support charity, and we asked the question, what is the current practice regarding gynecological cancer risk in Lynch syndrome in the UK? And what we found was a huge postcode lottery with real lack of consistency of care up and down the country. In some places, there was a complete lack of services. So some places were offering Lynch syndrome testing in endometrial cancer patients who were particularly young or who had a strong family history, and others were offering no such testing. Some places were offering gynecological surveillance for healthy carriers of Lynch syndrome, that is annual ultrasound scan, hysteroscopy and biopsy to look for precancerous and cancerous conditions of the endometrium, and other places were offering nothing. And this was due to a real lack of clinical guidelines, both national and international, and in turn due to a lack of research evidence underpinning what we should be doing. And so we convened the Manchester International Consensus Meeting, where we invited 52 stakeholders across Europe and North America, including patients and patient support groups, gynecologists, geneticists, pathologists, gastroenterologists, and so on. On the first day, we heard from the experts about the state of the science. And on the second day, we rotated delegates through working groups where topics were debated until a consensus was reached. And essentially, this process left us with these key questions. So for women with endometrial cancer, who should we be screening for Lynch syndrome and how should this be done? And for women with Lynch syndrome who had not yet had a gynecological cancer, was there anything that we could do to prevent endometrial cancer or indeed to detect it early should it occur? So to start to address these questions, we carried out a systematic review of the published literature to find out what proportion of endometrial cancers are associated with Lynch syndrome. We found 53 studies that had around 12,000 cases of endometrial cancer, and overall this study showed that there was a 3% incidence of Lynch syndrome in endometrial cancer patients. And that is exactly the same as the 3% incidence of Lynch syndrome in colorectal cancer patients. But what we did notice was that the quality of the available studies was really very poor, with few studies testing all eligible patients, no studies comparing the different testing strategies, and indeed all the studies had been carried out in private healthcare settings, where a Lynch syndrome diagnosis resulted in a hike in insurance premiums. And this meant that around 50% of people approached to take part in the studies had declined. And so we carried out the first UK prospective study called the PETAL study, proportion of endometrial tumours associated with Lynch syndrome, in order to find the first UK evidence for the proportion of endometrial tumours associated with Lynch syndrome, and also to try to define the best testing strategy for identifying them. This was a true multidisciplinary exercise with gynecology, myself, and Dr. Neil Ryan, who was an MRC-funded PhD student under my supervision at the time, genetics, Professor Gareth Evans, and pathology, Professor Ray McMahon. So we tested all of the patients attending our hospital over a 2-year period who had been diagnosed with endometrial cancer for Lynch syndrome. We also carried out a microcosting study to identify the costs associated with testing for Lynch syndrome in endometrial cancer, and an acceptability study where we asked the question, do women want to be tested for Lynch syndrome, and when is the best time to be offering that testing? And the results of the PETAL study are shown here. So of 500 women with endometrial cancer, 88 tested positive by tumour triage. And this means that when we tested all 500 women with endometrial cancer for mismatch repair deficiency using immunohistochemistry, or for MSI high, we were able to find 88 that tested positive by one of these 2 triage strategies. In addition to that, there were 12 patients who had a very strong family history, and there were 35 patients who were under the age of 50 at the time of diagnosis of endometrial cancer. So we tested all 135 of these patients by germline Lynch syndrome testing to see if we could find out exactly how many patients in our 500 cohort had Lynch syndrome. And after all this comprehensive testing, we found that 3% of cases did indeed have Lynch syndrome, which was the proportion that we were expecting from our systematic review. Of these 16 women, 3 were known Lynch syndrome carriers and 13 were new Lynch syndrome cases. The 500 patients had a very standard age, BMI, and stage and pathology profile compared with UK average. So this study was published in PLOS Medicine a couple of years ago. And the beauty of the study was really that because we did such a comprehensive testing strategy where we directly compared the effectiveness of immunohistochemistry for mismatch repair deficiency and MSI testing for identifying people with Lynch syndrome, we were able to show that the best way to identify Lynch syndrome patients in endometrial cancer was using mismatch repair deficiency by immunohistochemistry. It picked up all 16 of our Lynch syndrome cases. On the other hand, if we had just used MSI testing to select our patients for germline Lynch syndrome testing, we would have missed quite a significant proportion of the patients who subsequently were diagnosed with Lynch syndrome. If we'd used clinical predictors, that is young age, so if we'd used a cutoff of 50 years of age, we would have again missed lots of patients with Lynch syndrome. And indeed, we found Lynch syndrome all the way up to 70 years and beyond. And furthermore, if we'd relied on family history using different family history scores, again, we would have missed quite a lot of our patients who were ultimately diagnosed with Lynch syndrome. And this showed us that the best way of testing endometrial cancer patients for Lynch syndrome was to use mismatch repair deficiency by immunohistochemistry. Alongside this PETAL study, we carried out an acceptability study where we asked the question if women want to be tested for Lynch syndrome. And I think the overwhelming answer to that question was yes, because over 99% of women approached to have Lynch syndrome testing agreed to have it done. And this was when they were counselled by a gynecologist and only referred to genetics if they had a positive tumour triage or if they were at very strong risk of Lynch syndrome based on age and family history, as previously discussed. The main motivation that women in our study had for taking part was that they wanted to protect their family against future cancers. We also showed that the timing of asking women about Lynch syndrome testing was important. If we asked them in the preoperative setting, then they were obviously very anxious about their surgery and they found it a rather stressful question. But if we asked them at the time of seeing them back after their surgery for endometrial cancer when they came for their results, then they didn't find it a stressful thing at all. As I said, we carried out a microcosting study, which is essentially where you calculate every second of staff time per step, every microliter of reagent used, wear and tear of equipment and so on, to find out how much it actually costs to test a cohort of patients with endometrial cancer for Lynch syndrome. And again, we directly compared all the different testing strategies that we thought could be clinically useful. And we were pleased to find that the Manchester approach of using immunohistochemistry as tumour triage was not an expensive way of testing a cohort of patients with endometrial cancer for Lynch syndrome. That's not the same as asking whether or not something is cost effective and whether it's a cost effective use of our NHS resources. And so we paired up with Dr. Tristan Snowsill from the University of Exeter, and we carried out detailed cost effectiveness analyses to try to understand whether testing everybody with endometrial cancer could be cost effective for the NHS. And we were able to show that indeed it was, and that indeed the Manchester approach for testing endometrial cancers for Lynch syndrome was cost effective versus no testing at all at £5,495 per QALY gained, which is well below the threshold considered cost effective in this setting. And so this is now the way that we recommend that endometrial cancers be screened for Lynch syndrome. So all tumours should be screened by mismatch repair immunohistochemistry, and those who test mismatch repair proficient, that's around 3/4 of the tumours that we might test, can be reassured that they are at very, very low risk of Lynch syndrome. On the other hand, those who test MMR deficient, that is, they do not express one or more of the 4 mismatch repair proteins in their tumour, and again, they are MLH1, PMS2, MSH2 or MSH6, then these patients are at risk of Lynch syndrome endometrial cancer. So this is around 25% of all endometrial cancer patients. And in order to further select those in whom we will carry out germline Lynch syndrome testing, we carried out reflex testing of the tumour for MLH1 hypermethylation. And that is because the vast majority of Lynch syndrome, of endometrial tumours that are mismatch repair deficient, are actually sporadic tumours that have hypermethylation of their MLH1 promoter. And so if we can show that they do not have hypermethylation of MLH1, then this makes them more at risk of having Lynch syndrome. So ultimately, these two tumour triage tests will define a group of women who are at increased risk of Lynch syndrome and in whom we would recommend they were referred for germline Lynch syndrome testing. This is around 10% of all endometrial cancer patients. And after germline Lynch syndrome testing, around 3% of all of our endometrial cancer patients will be diagnosed with Lynch syndrome. And this then enables them to have their family members contacted and tested, and for them all, the family members that test positive and the index endometrial cancer patient to engage in cancer prevention interventions like bowel cancer screening, taking aspirin, and engaging in lifestyle choices that reduce their risk of future cancers. So we took all of this information to NICE, and in October 2020, we were delighted that they issued new guidance that matches the already existing guidance in colorectal cancer, that again recommends that all endometrial cancer patients be offered testing for Lynch syndrome, and that they recommended that this be done using tumour triage with immunohistochemistry, looking for mismatch repair deficiency, followed by MLH1 methylation testing as appropriate, and then only germline Lynch syndrome testing those who are triage positive. So this really matters to patients. So this is one of our patient representatives who said, "I'm so pleased that women diagnosed with womb cancer will now be offered testing for Lynch syndrome and the difference this will make to so many women and their families." And Genevieve Edwards, the chief exec of Bowel Cancer UK, said, "This excellent decision by NICE will undoubtedly save lives from bowel and other cancers by identifying more people at risk through Lynch syndrome." It also resulted in us winning a whole load of prizes that essentially recognised the importance of our work in changing clinical practice for diagnosing Lynch syndrome in patients with endometrial cancer. So what about healthy carriers with Lynch syndrome then? Obviously, if we diagnose Lynch syndrome in a patient with endometrial cancer, they will have family members who ultimately will also be diagnosed with Lynch syndrome who may not have had a gynecological cancer. So is there anything that we can recommend to these healthy carriers of Lynch syndrome to help them prevent endometrial cancer in the future? And this is all about understanding a person's individualized risk of Lynch syndrome associated cancers. So we did some work that was published in JAMA Oncology around 5 years ago that showed that it matters which mismatch repair gene is affected in Lynch syndrome. And it also matters what type of mutation that person might have. So in other words, if they have MLH1 or MSH2, then they tend to be diagnosed with cancer at an earlier age than those who have MSH6 or PMS2 pathogenic variants. And again, if they have non-truncating pathogenic variants in MLH1, then that is associated with an earlier age of cancer onset. And all of this information has now been incorporated in an online calculator through the prospective Lynch syndrome database that enables an individual with Lynch syndrome to calculate their own individualized risk of different cancers in Lynch syndrome. And of course, a healthy carrier of Lynch syndrome may choose to reduce their risk of gynecological cancer by having a risk-reducing hysterectomy and bilateral salpingo-oophorectomy once they have completed their family. And we wanted to know what the optimal timing of this risk-reducing surgery might be. So again, we paired up with the prospective Lynch syndrome database, and we looked at over 2,000 female Lynch syndrome carriers who had been followed up for a whole a large number of years, during which time some of whom had developed endometrial cancer. And if you can see in this table here, the highlighted row shows that up until the age of 40, the risk of endometrial cancer, irrespective of the mismatch repair gene that is affected by in Lynch syndrome, that there's a really very low risk of endometrial cancer and no risk of dying from endometrial cancer. However, after the age of 40, the risk for endometrial cancer starts to climb quite rapidly, particularly in carriers of MLH1 and MSH2 pathogenic variants, and that this risk continues to climb all the way out to 70 years of age and beyond, suggesting that it is never too late to offer risk-reducing surgery in Lynch syndrome, but that the optimal timing of this might be after around the age of 40 in MLH1 and MSH2 carriers, and perhaps after the age of 45 or even 50 in those who have MSH6 or PMS2 pathogenic variants. So finally then, I just want to briefly touch on whether or not we can offer anything to healthy carriers of Lynch syndrome who are not yet ready to have risk-reducing surgery and who want to know whether they have developed a precancerous lesion or an early cancer of the endometrium. So the question is gynecological surveillance of value for women in Lynch syndrome? And unfortunately, there is no good evidence that it is. So endometrial cancer presents early and in general has a really good prognosis. And so there is no evidence that gynecological surveillance improves those outcomes. And indeed, the investigations that we use for symptomatic patients, for example, women with postmenopausal bleeding, who we do not think are at risk of Lynch syndrome, are not that helpful in a predominantly premenopausal group of women and for repeating on an annual basis. So transvaginal ultrasound scan is of limited value before the menopause because there is normal cyclical fluctuation in endometrial thickness that does not predict endometrial abnormality. And hysteroscopy and endometrial biopsy are very effective at picking up atypical hyperplasia and endometrial cancer, but of course they are invasive and sometimes poorly tolerated and even painful, especially if we're asking women to have these tests done every year for surveillance. So clearly we need a better test. And there is a lot of interest in developing a non-invasive test for endometrial cancer for the purposes of surveillance in Lynch syndrome. And this is one example of a test that is showing great promise. This is the PAP-seq test. And in this study that was published about 4 years ago, you can see that if you take a cervical scrape and also an endometrial scrape, and then subject the cells in that scrape material to mutation analysis, then you can pick up endometrial cancer in around 93% of cases. But of course, an endometrial scrape is still an invasive test. And so there's a lot of interest at the moment as to whether or not you could actually find a cancer blood test, or whether you could use vaginal fluid that could be collected in a completely non-invasive way, or even urine as the basis of a non-invasive screening tool in Lynch syndrome. And this really matters for patients. So we carried out a James Lind Alliance priority setting partnership to identify the top 10 research priorities for detecting cancer early. And this question, what simple, non-invasive, painless, cost-effective and convenient tests can be used to detect cancer early, was ranked highest in that process, according to clinicians, patients and their carers. And ultimately, what we would love to develop is an endometrial cancer screening tool that is simple and patient-friendly and completely pain-free, preferably something that could be self-collected at home, whereby a sample could be posted to the laboratory for analysis, and only those individuals who test positive invited in for the more invasive diagnostic testing. And clearly, if we could find an accurate screening tool like this, it could completely transform what we offer our patients with Lynch syndrome for endometrial cancer surveillance. And with that, I'd like to thank Team Womb, with whom all of this work has been conducted, and without whom none of the data that I've presented today could have been presented, and also to thank you for your attention.
I think you can all join me in realising just how special that presentation is from Emma Crosby. It really does take you from end to end of the patient pathway of how to go about embedding Lynch syndrome. It's phenomenal, it really is. So thank you so much, Emma, for doing that video for us. Now we're slightly ahead of time, and I don't think that's an issue. So I think we might go to the intermission and comfort break now for 10 minutes. However, if I could ask you, if you do have any questions, would you be able to pop it into the chat now, or pop your hand up and we can answer any questions that you may have? Or if we don't know the answer, because I'm not the expert by any means, but I know who are, and we can ask them to answer your questions. And after the break, we're going to be joined by Professor Jim Hill, who is our clinical deputy director here at the Northwest GMSA, and he's a professor of surgery specialising in colorectal surgery. So that's really exciting. And top spot will be Mandy. Mandy Derbyshire is our regional Lynch syndrome clinical nurse specialist nurse educator. And basically she will be joining us and giving us a brilliant presentation about the nurse's role and all the work that she's been doing across our region. And then we've got an exciting MDT discussion. So there's going to be 3 case studies that will be presented, and it will give you some real good insights into some of the questions and some of the nuances of particular cases that have had a Lynch syndrome diagnosis. So we'll go for a comfort break now between 10:40 and 10:50, and we look forward to seeing you after the break. We're going to be playing our video now. So this is a simulated patient interview for Lynch syndrome genomic testing. And we got feedback from the REEF webinar series that people wanted to see a real kind of role play about how to have that genomic conversation with patients. So please give us some feedback on our video, and all feedback welcome. Thank you. Okay, so welcome back, everybody. So there's been quite a bit of chat in the chat function, which is brilliant. So Dean has asked a great question about aspirin, which I know that Mandy touches on that within her talk, but we'd also like to bring that to the MDT discussion, if that's okay. Dean, let me know if that's all right with you. I have put a lovely explanatory Lancet article there in the chat for you, that link, and I've also done a link to the NICE patient decision making aid, which is a really good resource that we often signpost to. Louise, yes, you're going to be able to access a link to the recording. I'm not completely certain yet, but I suspect we're going to be having a link through our website. So hopefully one of the team can just pop into the chat function the link to our website. Mandy, you've been reaching out to I can't get, let me just see. To our colleague down in Barts in London. Brilliant, you're very welcome. Lovely to hear from you. And that's great to know that you, so if those of you are not aware that on the call within England, we have 7 genomic medicine service alliances that cover the whole country. So wherever you are in your particular area, trust or service, you will have access to a regional Lynch syndrome clinical nurse specialist, nurse educator. So if you want to pop a question into the chat to find out who yours is, we'd be more than happy to share that with you. Debs Lakeland. Hi, Debs. Am I correct in thinking the new Lynch patients will undergo surveillance? Yeah, that's another really important question, and that's something that Mandy will be touching on, and also Jim. And again, let's bring that to the MDT discussion. Have I missed anybody's question? Let me just... Anybody? Beatrice, brilliant. That's great. Thanks for your... does anybody else want to ask a question in the chat or indeed put their hand up? So Professor Jim Hill, Jim's at a conference / really important, very important meeting, and he's scheduled to join us at 11. So and he'll be doing his talk. I think Jim might be with us already.
Yes, I'm with you. Yes.
Oh, lovely. Jim, thank you very much. We've had a couple of things in the chat that we can make sure we allude to. It was things like the importance of aspirin and a bit about how do we do the surveillance for Lynch with the new changes to the bowel screening programme. So over to you, Jim. Thank you.
Thanks very much, Marie. Could I have the first slide, please, Rainis? So I'm starting with this slide because I really just wanted to reassure folk that this is something that we've been doing for a long time, and what the changes that we're making really are, I think, reasonably straightforward, and we're not trying to turn people into amateur geneticists. And we've been very fortunate in Manchester for having a geneticist with a specific interest in inherited cancer for a very long time. So when we started this service about 25 years ago, some of the patients came to the geneticist and some of the patients came to my clinic. I wanted to reassure you that I've never tried to draw a proper genetic pedigree, and we don't expect you to, but I always did take a good family history and describe that family history when I referred the patient to the genetics department. If the family history was in keeping with Lynch syndrome, and we even referred some patients who we didn't think merited screening, but where there was a lot of anxiety about the family history of cancer. And again, the genetics department provided great reassurance that this family didn't need screening. So if the family history was in keeping with Lynch, we arranged for the patient to have colonoscopies. We referred them to genetics. The genetics department verified the family history, checked with GP records and with cancer registration. They counseled the patient and they did the mutation testing. Patients were given the results by the genetics department and they arranged cascade testing for the family. And we arranged repeat screening via endoscopy with the genetics department oversight to make sure that patients had the right screening interval. But that was really a sort of local service. It wasn't run generally across the Northwest, so it worked well for the patients who were referred to us, but clearly didn't address the bigger issues of Lynch syndrome in the Northwest. Next slide, please. So we were very pleased to see that in 2017, as Fiona's already mentioned, that there was nice guidance for reflex universal testing for all colorectal cancer cases. And then a little later, that was also recommended for endometrial cancer. Next slide, please. None of these initiatives work really without proper funding, and the money was made available by NHS England, and there was planning and contracting guidance which made a priority for the cancer alliances across the country to implement the Lynch syndrome testing and surveillance pathway. And a handbook was provided telling alliances exactly how to go about doing that. Next slide, please. The Northwest Genomic Medicine Service Alliance has been working in partnership with the cancer alliances in order to achieve this universal testing for colorectal and endometrial cancer. And I have to say that joint working actually has been very effective. There's been a colorectal and endometrial cancer Lynch champion in every MDT. We've provided regional support, and there's been training for all the frontline clinicians involved in the project. Next slide, please. So the specific remit for the Lynch syndrome is the reflex testing and the mainstreaming, but just a word or two about the Genomic Medicine Service Alliances. And one of their remits is to embed genomics into routine care locally and across the whole population, establishing testing pathways, importantly to enable clinicians to request genomic tests and to help them with their understanding and perhaps most importantly, the confidence to utilize genomics safely and effectively. Next slide, please. So I'm really talking about the first part of the National Lynch Project, and Mandy's talking about the second part, and it's how we go about ensuring reflex testing is in place for colorectal and endometrial cancers. Next slide, please. So you've already seen this slide, but it certainly bears repetition. So we're looking at the biopsy being sent to pathology, ideally for colorectal cancer, on the preoperative biopsy taken at lower GI endoscopy. But if that's not been done, then it would be done on the main cancer resectate. So if there is a mutation in MSH2, MSH6, or PMS2, then that patient may have Lynch syndrome, and the patient would go on to have consent for germline testing. If there is an abnormality in the MLH1 immunohistochemistry, then the patient for colorectal cancer has two additional tests, the BRAF mutation. If that's tested, it's very unlikely the patient has Lynch syndrome. And if the patient has, then we do an MLH1 promoter hypermethylation. And if that is positive, again, it's against the patient having Lynch syndrome. If there is no MLH1 promoter hypermethylation, again, this test suggests the patient may have Lynch syndrome, and they would go on to have consent for germline testing. Next slide, please. So what's required from the clinical team? We need to ensure that there is reflex testing done, that initial immunohistochemistry result is acknowledged and the result understood. And it's important just to note that although Fiona mentioned MSI, that's pretty much universally across the Northwest is we're doing immunohistochemistry as the initial screening test. So if the initial test is in keeping with Lynch syndrome, then if there is an MLH1 deficiency, the patient would have methylation testing and BRAF testing. Again, the clinical team needs to acknowledge the result and understand the terminology. And then for patients whose results are in keeping with Lynch syndrome, they would go on to consent for germline testing. And then if that germline test is positive, the patients would be referred to genetics. And by positive, I mean that a pathogenic mutation has been identified on the germline test. Next slide, please. So we were doing poorly in 2019 when the initial NICE guidance for reflex testing came out. Please, let's just say that you can't really see where the regions are which did badly, but the Northwest regions are on the right side, sadly, of the panel. But despite a poor start, the last audit data we did in December 2022 showed a very dramatic improvement, where we have got nearly 90% in endometrial, and we're now over 90% for colorectal, which is the national target for the testing level. Next slide, please. So there are some very considerable benefits to screening. Fiona talked about the advantages in terms of the reduced risk of developing colorectal cancer, and Kevin Monaghan talked about the increased survival, increased 7 years of life from colonoscopic screening. There is risk reducing surgery, mainly gynecological surgery, which you've heard about. There are advantages to aspirin therapy, which we'll perhaps ask Fiona to talk about in the MDT discussion, and lifestyle advice. The information is useful in directing surgical care, principally in whether the patient has a subtotal or a segmental colectomy, and that's an important part of the patient consultation, where the diagnosis of Lynch syndrome is known prior to surgery. And there are some important benefits with regard to chemotherapy decisions, and in particularly with immunotherapy. Again, we'll have some more discussion of that in the MDT. Next slide, please. So again, I think this bears repetition. So for MMR gene pathogenic variant carriers, MLH1 and MSH2, the disease tends to occur earlier than in MSH6 and PMS2. So it's 2 yearly screening from 25 to 75. And for MSH6 and PMS2, the screening starts later, to a decade later, and is from 35 to 75. And there is no evidence for screening for any other GI organ outside a clinical trial. And my understanding is it is now this month that the patients with pathogenic mutations will be taken over by the bowel cancer screening program. And certainly that removes a big headache in worrying about whether the patients are reattending for repeat screening, and also ensures a very high standard for screening in these patients. Next slide, please. When we first started screening for patients for Lynch syndrome. We anticipated that by removing the precursor lesion, the colorectal polyp, that we would prevent patients from developing colorectal cancer. And when we did see patients who developed cancers on screening programs, we were concerned that this represented a failure of our screening. But our experience has been mirrored elsewhere in the world. And it's thought that a lot of the Lynch syndrome carriers developed as de novo cancers rather than having the precursor lesion. And as again, you've seen from Kevin Monaghan, it is difficult to always identify the cancers early. Some of them can be quite subtle. So it's important that patients understand that there is still a risk of colon cancer developing despite being on the screening program, but we have seen the very significant benefits for screening. And even if patients do develop cancers on screening programs, the 10-year survivals are extremely good. Next slide, please. Just want to talk a little bit about the immunotherapy for Lynch syndrome cancers. So all patients which are mismatch repair deficient or MSI cancers tend to have a prominent tumor infiltrating lymphocytes. So it's known that for a very long time that the lymphocytes have been present, but it's not been well understood why, despite having the lymphocytes around the tumor, that these aren't more effective in actually helping to destroy cancer cells. And it's been shown that MMR deficient cancers are very immunogenic because they have a very high mutation rate. So develop lots of antigens on the surface of the cancer. So they're very antigenic. There are lots of white cells there. So why don't the white cells work properly? Next slide, please. And indeed, we can see in very occasional rare cases that the host is actually able to remove the cancer in its entirety. So this these panels show some images showing spontaneous regression of a transverse colon cancer, which had high frequency microsatellite instability. Next slide, please. So the mechanism where you have lots of lymphocytes, but they aren't able to destroy the tumor, is explained by what are called immune checkpoint inhibitors. So if we look at the left side of the slide, we can see a tumor, mismatch repair tumor, which is highly mutagenic and has got lots of neoantigens on the surface of the tumor. So the T cell comes along and recognizes these neoantigens, recognize it as foreign cell and destroys it. But in doing so, there is an inflammatory reaction, and the cytokines and other factors in the milieu of the inflammatory reaction cause something called the PDL ligand to be expressed on the tumor. This reacts with the PD1 on the protein on the T cell and abrogates the immune response, so that although there are lots of T cells present around the tumor, because of the PDL1 protein reacting with PD1, the immune response is abrogated. So the immune checkpoint inhibitors really are an antibody to the PD1 on the T cell. So it stops the T cell being inactivated and can continue to destroy the tumor bearing the abnormal neoantigens. Next slide, please. And when we look at new oncological therapies, for most of the time we're looking at a small difference in effectiveness compared to standard chemotherapy drugs. But the immune checkpoint inhibitors really are game changers in the dramatic improvements that they achieve over existing chemotherapy agents. So this was a pembrolizumab, which is an immune checkpoint inhibitors in treating microsatellite instability, high advanced colorectal cancer. And it shows that compared with standard chemotherapy, you have a much improved progression-free survival, and indeed the progression-free survival was maintained for long periods of time. And you look at the p-value and the top right of the panel, you can see a very dramatic, significant improvement using the immune checkpoint inhibitors in the mismatch repair deficient microsatellite in unstable colorectal cancers. Next slide, please. This was, so we've seen huge benefits from the immune checkpoint inhibitors in advanced colonic cancer, and there have been some recent studies showing really dramatic responses in patients with mismatch repair deficient locally advanced rectal cancers. And around 1 in 10 to 1 in 20 of all rectal cancers will be mismatch repair deficient. So they treated us, albeit a very small number of patients, and following the treatment with the immune checkpoint inhibitors, they re-imaged the patient and found no evidence of tumor on MRI, PET, endoscopy, digital rectal examination, or biopsy. The idea of the trial was that after the immune checkpoint inhibitions, patients, if there was any evidence of residual disease, would go on to have chemotherapy, chemoradiotherapy, or undergo surgery. At the point of presentation, no patients had required any additional treatments other than the immune checkpoint inhibition. And further improvement over standard chemotherapy is that there was treatment was very well tolerated. So the immune checkpoint inhibitors are going to dramatically change the way we manage the 5 to 10% of colorectal cancers that have this biological difference. Next slide, please. So I just wanted to finish by an important bit of information, which is the Lynch syndrome patients where there is this hereditary mutation of the MLH1, MSH2, MSH6, and PMS2 are responsible for around 4% of all colorectal cancers. But the reflex testing that we are carrying out will also identify an additional 10 to 12% of patients with sporadic colorectal cancer, which are biologically similar to the Lynch syndrome patients in that they are mismatch repair deficient cancers. But this occurs as a result of what's called epigenetic silencing of the MLH1 gene. And if there is methylation of the promoter region of the gene doesn't work properly. So in effect, the same end result as if the patient had a hereditary MLH1 mutation, but this occurs, if you like, as part of the aging process in some patients. So we're now up to around 1 in 6 of all our colorectal cancer patients that have this biologically distinct and important difference to other colorectal cancer cases. Next slide, please. So with regard to the National Lynch Project, where are we up to now? So the last 2 years, there's been a fantastic work by the cancer alliances and the local teams, and the reflex testing is now well established with over 90% compliance for colorectal cancer, which is the national target. We've had the REEF webinars, which we hope have provided the appropriate education to local teams We've done individual presentations to nearly all the MDTs in the Northwest region. Mandy's going to talk about her work with mainstreaming in the next talk. The bowel cancer screening program will take over the screening of all Lynch mutation carriers as of this month. And we're in the process, and we hope in the next 2 to 3 months to have the Northwest Specialist MDT established, which will allow clinicians to refer in cases where they would like some advice about the management of their Lynch syndrome patients. That's all I was going to talk about this morning. The one thing I did want to say, Mandy, was that although we are a little bit ahead of time, I think we will need to wait until the scheduled start of the MDT, because I think whilst Dina's was here, I think the other participants who are going to contribute to the MDT probably won't dial in until around about 11:50.
That's